So I believe that we finished the last conversation, discussion of leukocyte recruitment. Is that right?
Yes.
Yeah, I think so. So just, as a reminder, so far we talked about red blood cells, transporting oxygen from lungs to tissues and carbon dioxide from tissues to lungs. We talked about white blood cells, how they contribute to the protection against pathogens. And we specifically addressed the extravasation, the migration of white blood cells from the lumen of the vessel into the tissue, and how they follow chemotactic clues, how they follow cytokines finding their way to the site of injury. So the third type of cells that are the part of the formed elements in the blood, the platelets. So they are essentially cytoplasmic fragments. This image here shows you a hematopoietic stem cell on the left, and a hematopoietic stem cell progresses to become a cell called megakaryocyte. Now, these cells, megakaryocytes, can be found in bone marrow. Some of them are actually found in the spleen. Megakaryocytes are fairly long-living cells, and they pinch off the fragments of the cytoplasm, forming a platelet. Essentially, it's a nucleated cell. In some older textbooks, you will actually find the statement that platelets are simply the cell fragments. Many scientists that study platelets will disagree with you, to say the least. Most recent studies of platelets demonstrated that, first of all, platelets have mRNA, meaning that they do have some kind of a gene expression. They do produce proteins. There are ribosomes in the platelets. Moreover, it was shown that in response to various stimuli, platelets indeed can respond, by changing the gene expression, leading to alterations in the protein synthesis. Now, the first and foremost function of platelets, of course, is clotting, regulation of the clot formation, and regulation of coagulation responses. Molecules like serotonin, adenosine diphosphate, calcium are all necessary factors in regulating platelet activation and formation of a clot. Now, one really important function that is often overlooked by people who talk about platelets is that they are important regulators of inflammatory response. So in this picture on the right, it's a bit overwhelming, but I want to address just one part of that picture here. So this is a neutrophil, white blood cell, one of the main innate immune responders to the inflammation, to the tissue damage, to the infection. These are platelets, and you can see that on the left you see platelets interacting with a neutrophil, and platelets essentially recruiting neutrophil to a site of inflammation. And it was shown in multiple studies that activated platelets, and we'll talk about platelet activation in a bit, that activated platelets may not only form a thrombus, they may also activate leukocytes, activate white blood cells, initiating an inflammatory response. And once we go through thrombosis, once we go through the plug formation, you will see what is the importance of it for human cardiovascular health. So platelets are an essential component, the response called hemostasis. Hemostasis comes from two Greek words, hemos, blood, and stasis, being stagnant, okay, stopping. Hemostasis is the response to the blood vessel injury, response to the blood loss. Now this response involves two main components found among the found in plasma and in the formed elements. Plasma clotting factors form fibrin threads that reinforce the platelet plug, while platelets form the plug itself. So what happens during a vessel injury? Here on the step 1 to the left, you can see the vessel injury. Hold on a second. A vessel injury leads to the release of several factors, such as thromboxane A. I want to kind of put a special emphasis on this one because it will be important in our future conversation about coagulation. Epinephrine, serotonin, and as you remember, epinephrine leads to the contraction of the vessel smooth muscles and blood vessel contraction. Turns out serotonin does exactly the same. We mentioned the activity of serotonin when we discussed the hormones regulating digestive activities. And we figured out then that serotonin stimulates the activity of the smooth muscles in your stomach. The same story happens here. The release of serotonin from the damaged blood vessel leads to the blood vessel contraction. Now, why blood vessel contraction or vascular spasm is so important at being a first step in hemostasis? Think about this. If the vessel is damaged, the first thing that would be logical to do is to limit the blood flow to the damaged area. That's the vascular spasm. Of course, vascular spasm happens mostly in small blood vessels, in the microvasculature. If a large vessel is damaged, say it's a large artery, vascular spasm will not be able to prevent bleeding. We good? Now, when vessel is damaged, tissues that are located under the endothelial layer, so let's take a look at the right image. So this is the endothelial cell. This is collagen, okay? And that is a smooth muscle layer. So tissues such as collagen and smooth muscle get exposed to the blood, okay? And it turns out that so-called von Willebrand factor that is expressed on the fibroblasts of the connective tissue in lamina propria and on the smooth muscle cells facilitates platelet adhesion. Okay? Does that make sense? So platelets get exposed to the tissues that carry von Willebrand factor. Von Willebrand factor is like a Velcro that makes platelets to stick to that surface. Are you following me so far? Platelets not only stick to the site of the injury, they also get activated. Platelet activation is mediated by several chemicals, among those adenosine diphosphate and thromboxane A. Again, thromboxane A is our old friend from here. So now you know that thromboxane A mediates two parts of hemostasis. Mediates blood vessel contraction and mediates platelet activation. So far, you're following me? So now you've got two events. First, platelets are sticking to the surface of the damaged vessel. You know, they basically plugging the breached endothelium, and on top of that, platelets get activated. Platelet activation leads to the swelling, and in response to activation, they release pro-inflammatory and pro-coagulative factors. Now, what does that mean? Platelet gets activated and releases more thromboxane A. What is the effect of thromboxane A on the platelet activation? It leads to platelet activation. So single activated platelet activates more platelets. Those newly activated platelets will also release thromboxane A and activate more platelets. Now, this whole story, you can recognize a familiar positive feedback loop. Does that make sense? Do you understand what I'm saying? Like positive feedback? One activated platelet will release chemicals that will activate other platelets, that will activate other platelets, blah, 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 blah. It just spreads. Now, let me ask you a question. Did you ever see a platelet plug in you? I bet you did. Acute damage, you cut yourself and bleeding eventually stops, right? That's platelet plug. Did you die after that? Yeah, I doubt it. You're all alive here. Which means not all platelets got activated. So what regulates, what limits the platelet activation? Why they are activated only at the site of injury? Only right here. What's the reason for it? The reason is extremely elegant. It turns out that your endothelial cells release chemicals such as prostacyclin and nitric oxide. Release of prostacyclin and nitric oxide, and this is really important. When I say endothelial cells that release, only healthy endothelial cells release nitric oxide and prostacyclin. Does that make sense to you? So think about this. Look at the picture. I'm gonna erase all the scribbles. Look at the picture to the right side. So this part of endothelium on the right and on the left. Is this part of endothelium intact? Yeah, endothelial cells are fine. Any platelet adhesion there? No, because these cells produce nitric oxide and prostacyclin, and these molecules prevent platelet activation. When endothelium is damaged, production of NO and prostacyclin ceases, and platelets can get activated. Does that make sense? Now, platelets do stick to each other. You can see here, they stick through fibrinogen and fibrinogen receptor. They interact with each other through a molecule called P-selectin and P-selectin glycoprotein ligand, which is PSGL, which you don't really have to know. But platelets interact with each other relatively weakly. Okay? It's like you building a wall out of the bricks without any mortar. So you can imagine that platelet plug that is formed by platelets only should be fairly weak. The question is, can we reinforce it? Is there any additional mechanism that makes platelet plug stronger? The answer is yes. That last step of the hemostasis is called coagulation. And during coagulation, the platelet plug is reinforced with fiber. Coagulation cascades are mediated by a variety of enzymes, so-called coagulation factors or clotting factors, that are all synthesized in liver. Sort of a clinical tidbit about this is that people who have liver problems, like liver failure, cirrhosis, liver cancer, usually experience significant problems with the coagulation, because liver does not produce coagulation factors or clotting factors in the necessary amounts. Does that make sense? Now, few general things about coagulation pathways that we're going to be talking about in a minute. First of all clotting factors, almost all clotting factors are found in the plasma. So they are normally circulating in the inactive form. The exceptions are tissue factor. Where do you think tissue factor is found? Thank you very much. Yes, you're absolutely right. It's found in tissues. And another exception, not to the location, but to the principle. So coagulation factors or clotting factors activate each other. Exceptions are calcium, that is an ion, it doesn't have to be activated, and fibrinogen, which is essentially a last clotting factor to be activated. Fibrinogen is not an enzyme, okay? Along with calcium, it's not an enzyme. Am I clear? Now let's take a look at the coagulation cascades. There are two of them. Now this, if you feel confused, if you do not follow, please tell me immediately. It seems confusing. Can you please stop for a second, say it again, explain it differently, all right? So first of all, there are two pathways based on what initiates each. Intrinsic pathway. The word intrinsic, what does that mean? Huh? Inside, yes. So stimulus that initiates intrinsic pathway, is found inside of the vessel. The stimulus for intrinsic pathway is the tissue's underlying ruptured endothelium. Go back for a second. Look at the picture on the right. Ruptured endothelium exposes collagen and smooth muscle. Does that make sense? Extrinsic pathway is activated when deeper underlying tissue beyond the blood vessel is exposed to the blood, or I should say differently, when platelets blood interacts with the deeper tissue where tissue factor is found. Does that make sense? Do you understand the idea? As long as it's just endothelium, intrinsic pathway is stimulated. If the damage is deeper than endothelium, then extrinsic pathway will get activated. Am I clear?
You said deeper than endothelium?
Deeper than endothelium. If say, okay, let me explain it. Let me give you a more relevant example. Can you imagine a blood vessel? A venule. Can you imagine a venule? So you've got endothelial layer facing the lumen. Does that make sense? Under that endothelium is the basement membrane. Let's say due to some event, I don't know, not atherosclerosis. No, it doesn't sound right. The patient has sickle cell anemia. Sickle cell damages the endothelium, strips it. That exposes that basement membrane, mainly collagen, to the blood. Still, it's inside the blood vessel, right? It's a minor damage. But even this minor damage will activate intrinsic pathway, okay, and coagulation will start. Is that clear? Now, in case when you cut yourself with a knife, you exposing your platelets not only to the collagen in the blood vessel wall, you expose them to connective tissues, to muscles, to whatever's outside of that blood vessel. Does that make sense? An extrinsic pathway is activated. So far, we're clear. Let's take a look at intrinsic pathway. So the factors were named in the order they were discovered. So sometimes there's some of a sort of disorder in response to, say, exposure to the collagen, and in response to factors that are released by the activated platelets in the intrinsic pathway. Factor 12 is being activated. So I'm going to circle inactive forms in blue and active forms in red. Now, remember what I told you about the clotting factors. They are enzymes. Are you with me? They are enzymes. So when factor 12 is activated, it becomes an active enzyme, which in turn activates factor 11. Factor 11 is an enzyme that activates factor 9 together with the calcium and factor 7. Factor 9 activates factor 8, forming 9-8 complex, and 9-8 complex eventually leads to the activation of the clotting factor 10. Now we're going to stop for a second here. Okay? So 12 activates 11. 11 activates 9. 9 activates 8, and they complex together. You with me so far? Now what happens in the extrinsic pathway? In the extrinsic pathway, tissue factor, with the assistance from calcium, activates number 7. Okay, forming tissue factor, factor 7 complex. And what is the effect of that tissue factor, factor 7 complex? It also leads to the activation here of factor 10. Now let me back up for a second and spend some time on several concepts related to intrinsic and extrinsic pathways. My question for you, question number 1, which pathway is faster? Extrinsic. Why? Fewer steps, yes. So extrinsic pathway is faster. What is the result? And I'm giving you winking hint. What is the result of intrinsic pathway activation? Activated factor 10. What is the result of extrinsic factor activation? Activated factor 10. So extrinsic and intrinsic pathways converge, activating the same clotting factor. Does that make sense? We're clear? We're good? Now what's the role of factor 10 here? Factor 10 activates factor 5 and 10, 5, calcium and phosphatidylserine form a molecule that is called prothrombin activator. Trying to put it in a nutshell, we can say that both extrinsic and intrinsic pathway converge at the activation of factor 10, which leads to the formation of a protein complex called prothrombin activator. Does that make sense? Absolutely. Intrinsic and extrinsic pathways converge on the activation of clotting factor 10, which leads to the formation of a protein complex called prothrombin activator.
Can you say it one more?
I bet I can. I can say it one more time. Extrinsic and intrinsic pathways converge on the activation of a clotting factor 10, which leads to the formation of a protein complex called prothrombin activator. Try not to look at anything else and just tell me, what is the function of prothrombin activator? It activates prothrombin. Okay, that's the name. So yes, indeed, it activates prothrombin, sometimes called clotting factor 2, converting it into thrombin. Thrombin activates fibrinogen, which is, remember, a soluble protein found in the plasma, converting it into insoluble fibrin polymer that forms this cross-linked network of fibers, trapping red blood cells and platelets in the clot. Does that make sense? No?
Can you go right again?
Yes. So prothrombin activator, right here, is basically the enzyme. So its function is to convert prothrombin into thrombin. That step, does that make sense?
Yeah.
Now thrombin is active enzyme. It is an enzyme. And the function of the enzyme called thrombin, specifically thrombin, not prothrombin, thrombin. Prothrombin is an active form. Thrombin is active form. So thrombin converts soluble fibrinogen, protein that is in the plasma, into insoluble polymer that we call fibrin. Fibrin forms, so that's long chains, basically fibers, name says it. Does that make sense? And these fibers of fibrin, they trap red blood cells and platelets in the clot. We're clear? Now, before we try to delineate what I will and will not ask on the exam, one thing that I will ask on the exam, you have to know what initiates intrinsic and extrinsic pathways, cascades, okay? What they converge upon. And you need to know that these two phases, phase 2, phase 3, here on the right, the blue and the purple shaded ones, this all together is called common pathway. Does that make sense? Yes.
What do you mean by what they convert upon?
Oh, so look at this. Hold on. So look at the left side, the phase 1. What is the ultimate result of the intrinsic pathway? Factor 10, right? Factor 10 activation. What's the ultimate result of extrinsic pathway? Factor 10. They converge upon factor 10. They come together. We good? Before we move on, I have no intention of moving on before all questions are answered. So far, any questions? What you need to know? Sequence all the way to factor 10. Sequence all the way to factor 10. What I will not ask you, I will not ask you to memorize the word phosphatidylserine, and I will not ask you to memorize the word calcium. So as long as you can tell me, okay, 12 activates 11, 11 activates 9, 9 activates 8, they friend together activate 10, that's your intrinsic. Tissue factor activates 7, they form complex together, activate 10, you're fine. Does that make sense? So this one, just steps, just basic steps. Second, what is the result of that convergence? What is the result of factor 10 activation? Formation of prothrombin activator. Does that make sense? That's what I can ask you. I can ask you, what is the function of prothrombin? Activates, converts prothrombin into thrombin. Direct action. Does that make sense? What is the action of thrombin? Converts fibrinogen into fibrin. What is the function of fibrin? To reinforce the clot. Any questions? Any uncertainties? Anything that is not clear in terms of what I can ask you? No? Okay. I'm 70% done with the study guide. I would say even 80% done with the study guide. So if I'm really lucky, I can finish it today. Okay. For this unit. Okay, got it? Now, we still have one question unanswered. So you have an endothelial damage, you have a vessel damage, the clot is formed, and what's next? Does it stay there forever? Obviously not. So first of all, platelets as cells start to contract, they move together closer, and they fix the opening, okay? Ruptured ends get squeezed together. Does that make sense? I mean, it doesn't do the job yet, but you have to put the ruptured ends of endothelium closer. So then platelets produce platelet-derived growth factor, and endothelial cells produce vascular endothelial growth factor, PDGF and VEGF. Okay, so what essentially happens? A PDGF, platelet-derived growth factor, stimulates the regrowth of connective tissue and smooth muscle in the vessel wall, while VEGF stimulates the regrowth of endothelium. You with me? And here's the deal. Smooth muscles grow back, connective tissue, fibroblasts, grows back, endothelium grows back, vessel is repaired. so far? We clear? Yes. So, platelet-derived growth factor, PDGF, stimulates the regrowth, the proliferation of fibroblasts, that's connective tissue in the blood vessel, and smooth muscle cells, that's muscle, while VEGF, or vascular endothelial growth factor, stimulates the regrowth of endothelium. We clear? So, vessel has grown back. What about the clot? What limits the clot growth? Why don't we have a massive... Again, look at this. Couple more things about the cascades. First of all, why do we call this a cascade? Do you understand? Because the previous enzyme, such as factor 12, will activate the next one, which will activate the next one, which will activate the next one. Does that make sense? This is why we call it a cascade. The previous part of the cascade activates the future part. Okay? Now, if you will imagine this, it seems absolutely reasonable to imagine that once you have a single intrinsic or extrinsic activation event, all fibrin in the entire blood all fibrinogen in the entire blood will be converted into fibrin. Why doesn't it happen? Well, there are few really elegant mechanisms that regulate fibrin activation and actually destroy the fibrin. So, first of all, as you can imagine, at some point clot has to be disassembled. We clear? The enzyme called tissue plasminogen activator, which is essentially regulated by the same mechanisms that PDGF and VEGF, the repair process. Tissue plasminogen activator, now think about the name. Tissue plasminogen activator. What does it activate? Which protein? Plasminogen. It converts plasminogen into plasmin. And plasmin, its sole function, it's basically a protease. It's the enzyme. Plasmin breaks down fibrin into degradation products like short peptides. Now, remind me please, what was the function of a fibrin? To reinforce the clot, right? Those threads reinforced the clot. If fibrin is gone, what happens to the mechanical resilience of that clot? Goes down, so blood flow can actually take those platelets away. Does that make sense? I'm sorry. Now, what else? Well, clot is formed not in the stagnant blood. Clot is formed when the blood is moving. Like a vessel repair happens while the blood is moving. Does that make sense? That blood moving actually removes clotting factors that are excessive. It dilutes them basically. Does that make sense? So all that thrombin that is formed at the site of injury, the vast majority of it will be taken away by the blood itself. It will be diluted by the blood. Does that make sense? Another super elegant mechanism is that thrombin binds to fibrin. Can you remind me, what's the function of thrombin again? No, I know. I'm checking you. I know what's the function of thrombin. What does it activate? Thrombin.
Turns the fibrinogen, which turns into fibrin.
It converts fibrinogen into fibrin. And turns out that thrombin binds to fibrin. The more fibrin is formed, the less free thrombin is left. Does that make sense? Okay, look at this common pathway again. So, thrombin binds to fibrin. So, the more fibrin you have, the more thrombin will be bound to it, the less free thrombin you're going to have. It will automatically slow down clot formation. Does that make sense? There's a protein called antithrombin that inactivates thrombin that's not bound. So thrombin levels are very tightly controlled. Okay? Does that make sense? On top of that, the inflammatory cells, such as basophils and mast cells, release heparin, which stimulates antithrombin, which inhibits thrombin. So heparin, you know heparin, right? Anti-clotting medication. That's a natural anti-clotting medication. And as we mentioned before, nitric oxide and prostacyclin, they both prevent the activation of platelets and formation of a clot on the healthy endothelium, because nitric oxide and prostacyclin are released from the healthy endothelium, not from the damaged one. Okay? Now, I can show you the process of I'm incapacitated. I cannot regulate the lights of this thing. So I'm going to show you the process of clot formation in the arteriole that is located in the cremaster muscle of a mouse. I need to sort of, attribute the video appropriately. This video was filmed by a colleague of mine, Dr. Senchenkova, down in Louisiana State University in Shreveport. She's a terrific scientist. So it's a time lapse because it's a pretty long, I believe it's about 40 minutes, the whole thing. So in order for demonstration, she kind of cut out and sped up certain parts of the video. And I will give you some sort of commentary of what's going on there. Okay, there we go. Okay, so can you see the blood flow? Can you see? Okay, that's the blood flow. And now you're gonna, in a second, you're gonna see how blood vessel starts to constrict. Do you see the constriction? So that constriction, I'm gonna pause it for a second. So at this point, the diameter becomes smaller. Constriction is mediated by thromboxane A that is released from activated platelets. Now, one thing that I didn't address before we started watching this movie, mouse has a lot of blood vessels. How do we know that this particular blood vessel at this particular time will have thrombosis? We don't. We stimulate it. This mouse receives a dose of a chemical which produces free radicals when it is exposed to the light. Those free radicals activate platelets. Does that make sense? So you shine the light, you see the light here, okay? So far, we're good? You shine the light, radicals are formed, activate platelets, platelets initiate the clot formation. Now you're going to see some accumulation of platelets here in the left side. And here you go. You see, clot starts to form, and then here it is blown away by the blood flow. Now here is the initial clot formation. You see the platelets that are sticking to the wall, but they still are carried away by the blood flow. But they start to accumulate. You see more and more of those. More and more. And there is no clot on the undamaged endothelium. So they're going to start to accumulate. They can accumulate more. It's time lapse now. And finally, you have a complete occlusion of the vessel. Okay? Now that is a one small arteriole, so for well-being, well, it's a terminal surgery, so these mice, they sacrificed at the end of the surgery. But for that time being, that's not lethal. Okay, that's just one blood vessel that is occluded. Does that make sense? Yes.
This is kind of random, but kind of not. When someone has like a bad bloody nose and it won't stop and they get cauterized, what happens to the blood vessel?
Cauterization? As far as I know, that's a denaturation of proteins in the blood. So they will basically form an artificial clot.
So that's what cauterization does?
Denatures proteins, yes. It doesn't, I'm not sure if temperature will trigger clotting, but that high of a temperature will probably initiate some complete denaturation of some proteins, and then that damage may speed up the clotting further. Okay. So why do we even do this? Why did Dr. Senchenkova look at this? Which, by the way, took 11 minutes 46 seconds to clot the arteriole. It's pretty good. I was wrong about 40 minutes. For some reason it stuck 40 minutes. In the venule, the time to establish the clot can be longer, often because, you know, it just takes a lot of time for the platelets to get delivered. Blood flow is slower. Okay. Now those are clotting factors. Disclaimer, you do not need to know them. I'm not going to ask, what is the clotting factor number 3? What's the name for it? Okay. Or 12. No way. What I want to highlight, a couple of things. Where are they found? The overwhelming majority, except for calcium, and tissue factor, found in the blood and produced by liver. Does that make sense? Tissue factor is just found in tissues, and calcium is calcium. We're good? Now, a few words about the coagulation pathologies. Thrombocytopenia, low platelet count, can be the result of cancer, probably some drugs, radiation, either as the professional, occupational exposure to radiation, or exposure to radiation when you undergo before bone marrow transplant. Okay, it may lead to thrombocytopenia. Infection with meningococcus or Neisseria meningitidis. This is the two clinical signs of thrombocytopenia. So petechia are little small blotches on the skin. Basically, those are little subcutaneous bleedings. That's a hemorrhage. Okay, the larger blotch is called purpura. Okay. Now, what else can cause thrombocytopenia? I mentioned liver function. Okay, malabsorption of fat, anything like that. So, impaired liver function will affect the production of coagulation factors, and malabsorption of fat leads to deficiency of vitamin K, which is necessary for coagulation. Now, I want to be very specific about this. Petechia and purpura, it's not a disease, it's a sign. Moreover, technically speaking, thrombocytopenia is not a disease, it's a sign. You see, it can be a sign of a cancer, it can be a sign of an infection, it can be a sign of radiation exposure. Another fascinating disease is hemophilia. There are 3 types. Hemophilia A is a deficiency of factor 8, hemophilia B factor 9, hemophilia C factor 11. That I can ask. That's few numbers that I can ask. So in hemophilia, if you would look at the pathways, you will notice that hemophilia A, B, and C all affect intrinsic pathway. You know? Question?
IX is 9.
Say again?
Okay.
Got it.
IX, yeah, it's 9. You know where those Roman numerals came from? That's 5, like V. That is 5, like V. 5. That is X. 2 hands. And if I is 1, right? That's 1. So if I is on the left, it's subtracted. If it's on the right, it's added. Anything on the left is taken out. Does that make sense? So if you have 10, and then on the left I, meaning that this 1 is taken out of the 10, meaning 9. Okay. So hemophilia it's a terrible disease because it causes poor blood clotting, affects intrinsic pathway, bleeding, bruising, fever because of the general inflammatory response, platelet transfusion, injection of clotting factors. I had a student in my micro whose son had hemophilia. Clotting factors are astronomical, like price-wise, thousands of dollars per injection. They are very, very expensive. And platelet transfusion is expensive as well. So if you have a lot of time, go to American Red Cross and give your platelets. I would love to, but every time they are around, I have time only for regular blood donation. But donate your blood. Now, you know that hemophilia B was pretty common in the royal families. It's the sex-linked or X-linked recessive condition, meaning that it is found in one of the X chromosomes. And in women, so women of royal blood in Europe were carriers of hemophilia B. They were not sick. And male offspring could be sick if offspring inherited that particular X chromosome carrying the recessive allele from the mother. The most famous case, of course, is the Russian heir to the throne, Prince Alexei, who was the only male offspring of the last Russian Tsar Nikolai II. He had hemophilia B because his mother, Empress Alexandra, I want to say. I always mix up 2 empresses, Maria and Alexandra. I think she was Alexandra. Screw that. I think she was Alexandra. She was a carrier. But the interesting story is that that gene rose, as far as I remember, from one woman, Queen Victoria. She had a bunch of kids. And those kids ended up in different royal families. British royal families, Spanish royal families, German royal families, and Russian royal families. Her offsprings were so related that German emperor and Russian Tsar during the World War I, they were cousins, like first cousins. They were like writing each other very like heartful letters during that onslaught. When people were dying, they were just, I don't like the whole thing that goes on in Europe, Nikki. They called the German emperor called his cousin Nicky. Anyway, the funny part is that because of that offspring distribution, German royal court and Russian royal court ended up with hemophiliacs, and British royal court, where Queen Victoria were, ended up with no hemophiliacs. So it happened just by chance. It's called bottleneck effect. Okay. Now, there was some study recently on the treatment of hemophilia by using some gene therapy approach. I think it was quite efficient. They managed to I think, even cure hemophilia. But this approach is very expensive yet, and it's at experimental stage. So I don't think we're going to see some mass curative treatment of hemophilia in the foreseeable future. Okay? Now, you may encounter patients with hemophilia in your healthcare career, but most likely the condition that you will see very often is disseminated intravascular coagulation, or DIC. I don't remember. Yeah, I mentioned. That's the song by the band called Viremia. So the process is exquisitely beautiful, I would call it. So in the small vessels, multiple clots are formed, which means the blood is completely deprived of platelets. Does that make sense? All platelets are gone. They are in the clots. So blood cannot clot, and the blood vessels, on top of that, due to the inflammation, become really permeable, and blood starts to seep into the peripheral tissues. But on top of that, when all your small vessels, all your microvasculature is clogged, blood flow essentially holds to an end. Make sense? So it's kind of an interesting thing. You have massive clotting, and on top of that, blood cannot clot because all clotting already happened. So blood starts to leave into the peripheral tissues and blood flow stops. What causes DIC? Shock. It's another name for septic shock, sepsis, disseminated sepsis, infection. It's very common in patients who had some sort of a generalized infection. I don't remember if I mentioned toxic shock syndrome. Yeah, that's the result of it. Ultimately is DIC, disseminated intravascular coagulation. Okay. As far as I know, treatments are really futile for this particular condition. It's really hard. Transfusion reactions can happen, but they're quite rare because we try to match as good as we can. Now, that was pathologies, but sometimes, you know, clotting is bad, right? So, formation of a clot in the peripheral blood vessels, such as the deep veins in the leg, it's called a deep vein thrombosis, or DVT, can ultimately lead to myocardial infarction or stroke if this clot dissociates from the wall of the blood vessel, travels through the systemic circulation, and ends up in one of the cerebral arteries or in one of the coronary arteries. So how can we regulate the clot formation? The first answer is aspirin. The mechanism is elegant. There is an enzyme that is called thromboxane synthase. And aspirin inhibits the enzyme called thromboxane synthase, essentially reducing synthesis of thromboxane A. And if you remember, we just mentioned this chemical 15 minutes ago. Thromboxane A is one of the key activators of the platelets. And there is no thromboxane A, platelets are not getting activated. Does that make sense? Now, the studies demonstrated that low-dose aspirin is actually beneficial in males. I mean, mostly in males, because generally speaking, women are at the lower risk of cardiovascular events. So, aspirin for a long time was prescribed as a routine or prophylactic drug for people, say, with atrial fibrillation, high risk of clot formation, or people with obesity or diabetes, or, I don't know, history of cardiovascular events in the family. Recently, American Heart Association, I think they changed the recommendation, and this is how evidence-based medicine works. They did a comprehensive review of the side effects of aspirin supplementation and the effects of aspirin supplementation, and they showed, so the review showed that administration of aspirin to people without any risk factors for cardiovascular disease, just people who are like 60 and over, does not have benefits. Benefits do not outweigh the risks, because the main risk associated with aspirin is what? If it inhibits clotting, bleeding. So it benefits outweigh the risk in people with clotting problems. But in people without any obvious predisposition to thrombosis, risk of internal bleeding,
May I have your attention, please? May I have your attention, please? There has been a fire emergency.